If you ask the family members of people with Alzheimer's disease what is the most important goal for their care, they will say comfort. What happens to people with Alzheimer's disease? They go back and forth between nursing homes, rehab units, hospitals. When they're in the hospital, they get even more blood tests and other burdensome procedures than similar patients who are not demented get, and they get less pain management. So just the opposite of what pretty much everyone agrees should be the overarching purpose of medical care in people with advanced dementia, what happens is basically a form of torture. Nobody's intending to torture people, but that's in fact what happens. We've become more knowledgeable as providers about the physiologic aspects of our patients, their blood work, their x-rays, their lab values. But I'm fearful that as we become more knowledgeable because we have more of these databases, that we're actually becoming less wise about the person in front of us. And it's very hard as we become more reliant on the technical aspects of care that we're having a harder time supporting the patient and family and learning about them and how we can best use the technology of medicine to reach their goals. So subspecialization, while it has led to a great deal of fragmentation and the splitting up of the patient into a different doctor for every single organ and every single disease, has also led to some measurable improvements in quality and outcomes. People live longer. People live better. The flip side of that is, as we have gotten a huge growth in the number of older adults, the typical older person has multiple diseases. We call that multimorbidity, meaning that in order to have the best specialist for every disease, many older people have 8 specialists. And what happens is every specialist works in their own disease space, in their own organ system, and who gets left holding the bag of the coordination and the communication? The sick elderly person with 8 different diseases and his or her exhausted caregiver. Even people with mild cognitive impairment can't handle coordinating 8 different specialists, appointments, medications, tests. Add to that an Alzheimer's diagnosis and the tremendous organizational and oversight burden of the family caregivers. And it's a disaster waiting to happen. I think it's imperative upon us as the clinicians to stop and take the time needed to explore the goals and values of the patients and families in front of us. Medical education and nursing and social work, all healthcare professional education, is a key piece of it. Right now in medical education, dementia patients are viewed as poor teaching cases. And the interns, the residents, and the students aren't asked to take care of them because they're not good teaching cases, even though this is exactly who they're going to be taken care of when they get out of medical school. We also need to get medical education out of hospitals. Where do the vast majority of people with Alzheimer's or other chronic illnesses live? At home, and in communities, and increasingly in nursing homes. Yet there is virtually no medical and nursing education at home or in nursing homes. We have a medical infrastructure that's built around the bricks and mortar of clinics and hospitals, and a payment system that mirrors those sites of delivery. We need to rethink the concept of infrastructure to include home as a location of care. I think we need to find ways to support families in advocating for wanting care at home and what that looks like. And I think we actually need to look at educating. This is an opportunity to educate our clinicians about how to deliver care in the home. Right now, the places where you can get reimbursed for delivering care is in your office, in the hospital, in the emergency department. It's very hard to make a living doing home visits, almost impossible. If you're going to go out and see your dementia patient in the home, let's say it takes you 45 minutes to get there, you're going to spend 45 minutes there. You're driving back for 45 minutes. Even if you bill Medicare at the maximal level, you are losing money hand over fist. So doctors don't do that because they can't afford to. We need to change the payment system so that clinicians are actually rewarded for meeting people's needs where they are
predominantly at home and helping them avoid dangerous, burdensome hospitalization.
The care that many of these patients need are good home health aides, good nursing assessments, and they need physicians and nurse practitioners to understand that care in the home can be done without needing x-rays, blood work, echoes, IVs. I think we need to educate people on just what can be done at home, but understanding that caring means supporting a patient and a family through expected clinical complications that, in the case of dementia patients, are really how these patients are going to pass away. It's not something that is taught in medical school. It's not something that's taught in residency programs. And the same, I think, is true with nurse practitioners. So it's an educational opportunity to reframe how we deliver care.